Welcome to Module 2 of our Tuberculosis Management series. In this module, we'll focus specifically on smear-positive pulmonary tuberculosis, which represents the most infectious form of TB and requires prompt, systematic management. This module will equip you with the knowledge and skills to recognize clinical presentations, apply appropriate diagnostic approaches, implement the standard treatment regimen, and establish effective monitoring protocols. By the end of this approximately 10-minute module, you'll have a comprehensive understanding of managing smear-positive pulmonary TB according to evidence-based guidelines.
Recognizing the clinical presentation of smear-positive pulmonary tuberculosis is crucial for early diagnosis and treatment initiation. The classic presentation includes both pulmonary and systemic symptoms that develop gradually over weeks to months. The hallmark pulmonary symptoms include persistent cough lasting more than 2 weeks, which is often productive and may contain blood-streaked sputum. Patients frequently experience chest pain, particularly with deep breathing or coughing, and progressive shortness of breath during activities they previously managed easily. Systemic symptoms are equally important and include unexplained fever, often with night sweats that can be profuse enough to require changing clothes or bedding. Significant weight loss, typically more than 5% of body weight over several weeks, is common and concerning. Patients often report profound fatigue and loss of appetite that affects their daily functioning. It's important to remember that the presentation can vary significantly. Some patients, particularly those who are immunocompromised, elderly, or have diabetes, may present with atypical symptoms or a more subtle clinical picture. Young children may present primarily with failure to thrive or developmental delays. Healthcare providers must maintain a high index of suspicion, especially when evaluating patients from high-risk populations or those with known TB exposure. The key is to consider TB in any patient with persistent respiratory symptoms, particularly when accompanied by systemic symptoms. The diagnostic approach to suspected smear-positive pulmonary TB follows a systematic pathway that combines clinical assessment with appropriate laboratory and imaging investigations. Sputum examination remains the cornerstone of diagnosis. We should collect at least 2 sputum specimens, preferably early morning samples when bacterial load is highest. The first specimen should be collected during the initial consultation, and the second should be an early morning specimen collected the following day. If patients cannot produce sputum spontaneously, sputum induction with hypertonic saline may be necessary. Acid-fast bacilli smear microscopy provides rapid results, typically within hours, and remains an essential first-line test. However, we must remember that smear microscopy has limitations. It requires relatively high bacterial loads to be positive and cannot distinguish between different mycobacterial species. Expert MTB/RIF Ultra has revolutionized TB diagnosis by providing rapid molecular detection of Mycobacterium tuberculosis and rifampin resistance within 2 hours. This test is more sensitive than smear microscopy and should be used as the initial diagnostic test when available, particularly in high-risk patients or when drug resistance is suspected. Chest radiography is essential for all suspected TB cases. Classic findings include upper lobe infiltrates, cavitation, and hilar lymphadenopathy, but presentations can be highly variable. Normal chest X-rays don't exclude TB, particularly in immunocompromised patients. Mycobacterial culture remains the gold standard for TB diagnosis and is essential for drug susceptibility testing. While culture results take several weeks, they provide definitive diagnosis and guide treatment decisions, especially for drug-resistant cases. Additional investigations may include HIV testing, which should be offered to all TB patients, and baseline laboratory tests including liver function tests before starting treatment. The standard treatment regimen for smear-positive pulmonary tuberculosis follows the internationally recommended approach of 2-EHRZ/4HR, a 2-phase treatment lasting 6 months total. The intensive phase lasts 2 months and includes 4 drugs: ethambutol, isoniazid, rifampin, and pyrazinamide. This combination is designed to rapidly reduce bacterial load, prevent emergence of drug resistance, and achieve early bacteriological conversion. During this phase, patients are typically most infectious and require careful monitoring. The continuation phase lasts 4 months and includes 2 drugs, isoniazid and rifampin. This phase consolidates the treatment gains and prevents relapse. The reduced drug burden in this phase improves tolerability while maintaining effectiveness. Drug dosing is weight-based and must be calculated carefully. For adults, typical daily doses are isoniazid, 5 mg per kilogram, maximum 300 mg. Rifampin, 10 mg per kilogram, maximum 600 mg, ethambutol, 15 mg per kilogram, and pyrazinamide, 25 mg per kilogram. Fixed-dose combinations are preferred when available as they improve adherence, reduce prescribing errors, and help prevent development of drug resistance. These combinations simplify treatment by reducing pill burden and ensuring appropriate drug ratios. Treatment should be given daily during the intensive phase. While intermittent dosing was previously used, daily therapy is now recommended for optimal outcomes. Directly observed treatment, short course, or DOTS, should be implemented for all patients to ensure adherence and monitor for adverse effects. It's crucial to emphasize that treatment duration cannot be shortened, even if patients feel better or become smear negative early in treatment. Premature treatment discontinuation leads to relapse and potential drug resistance. Systematic monitoring throughout treatment is essential to ensure treatment effectiveness, detect adverse reactions early, and prevent treatment failure or relapse. Clinical monitoring should occur regularly throughout treatment. Patients should be assessed weekly during the first month, then monthly thereafter. At each visit, we should evaluate symptom improvement, weight gain, and general well-being. Patients typically show clinical improvement within 2 to 4 weeks of starting treatment. Bacteriological monitoring provides objective evidence of treatment response. Sputum smear examination should be performed at the end of the intensive phase, at month 2. If the smear remains positive at this point, treatment should be extended, and drug susceptibility testing should be considered. Follow-up smears should also be done at months 5 and 6, and at treatment completion. Laboratory monitoring is crucial for detecting drug-related adverse effects. Baseline liver function tests should be obtained before starting treatment, then monitored monthly or more frequently if abnormalities develop. Visual acuity and color vision should be checked before starting ethambutol and monitored regularly, particularly in patients receiving higher doses or those with kidney disease. Patient education is an integral part of monitoring. Patients should understand the importance of completing the full treatment course, recognize signs of adverse effects that require immediate medical attention, and know how to prevent transmission to others. Contact tracing and screening should be initiated promptly for all smear-positive cases, as these patients are highly infectious. Household contacts and close contacts should be screened for active TB and evaluated for latent TB infection.
The management algorithm for smear-positive pulmonary TB provides a systematic approach that ensures consistent, evidence-based care for all patients. The algorithm begins with clinical suspicion based on symptoms and risk factors, followed by appropriate diagnostic testing. Once smear-positive TB is confirmed, treatment should be initiated promptly with the standard 2-EHRZ/4-HR regimen while awaiting culture and drug susceptibility results. Key decision points in the algorithm include assessing treatment response at month 2, determining the need for treatment extension if smear conversion hasn't occurred, and managing any adverse effects that develop during treatment. The algorithm emphasizes the importance of DOTS implementation, regular monitoring, contact tracing, and patient education throughout the treatment course. In summary, successful management of smear-positive pulmonary TB requires prompt recognition of clinical presentations, systematic diagnostic approach using appropriate tests, implementation of standard treatment regimens with proper dosing, comprehensive monitoring for both effectiveness and adverse effects, and strong patient support systems. Remember that smear-positive patients are highly infectious until they achieve bacteriological conversion, typically within 2 to 4 weeks of appropriate treatment. Infection control measures are crucial during this period. This concludes Module 2. In Module 3, we'll explore the more complex scenarios of smear-negative and extrapulmonary tuberculosis. Thank you for your attention.